Okay, welcome back to part 3 of cardiovascular disorders. We are going to speak now about infective endocarditis, which is an inflammation of the inner lining of the heart, which is called the endocardium, particularly affecting that part of the endocardium in the heart valves. And this can lead to destruction of the heart valves, which can lead to fatal consequences. It's usually caused by strong bacteria called streptococci, very dense. Who can get this infection, infective endocarditis? Who are those patients at risk to develop infective endocarditis after dental treatment? And actually, it's not only related to dental treatment, it is related to any procedure that can introduce bacteria into the blood, that is bacteremia. Like, for example, any forms of endoscopy, upper endoscopy, lower endoscopy, or even urinary tract endoscopy. And the dental treatment is the same because most of the dental procedures can cause this state of bacteremia, and in certain patients, these 5 patients in front of us, can lead to this infective endocarditis. What are these 5 cardiac conditions in which they are at high risk to develop infective endocarditis? They are these 5 in front of us, which all of them are considered a structural abnormality of the heart. There's a problem in the structure of the heart. Like number 1, damaged heart valve after an attack of rheumatic fever. Number 2, previous history of infective endocarditis, which usually will leave complications on the structure of the heart after it gets resolved. Number 3, hypertrophic cardiomyopathy. Number 4, prosthetic heart valves, artificial heart valves, and temporary pacemakers. And number 5, congenital heart disease in children. So, number 1, damaged heart valves after rheumatic fever, previous history of infective endocarditis, hypertrophic cardiomyopathy, prosthetic heart valve, and congenital heart disease. Also with the temporary pacemakers. Pacemakers are of 2 types. I'm going to speak about that after a little while. We have the temporary and the permanent. The permanent has no problem with infective endocarditis, but the temporary pacemakers, if there is a temporary pacemaker, you should be aware that this patient is at high risk to develop infective endocarditis. So how to protect the patient against the risk of infective endocarditis? Typically, 1 dose of antibiotic, 3 grams of amoxicillin, orally taken 1 hour before the dental treatment. And what are the dental treatments that can lead to this bacteremia? There are 9. The first one, the dental extractions, procedure raising mucosal mucoperiosteal flaps, biopsies, subgingival procedures like orthodontic bands, scaling, irrigation of periodontal pockets, intraligamentary injections, reimplantation of avars teeth, incision and drainage of abscesses, dental implants, and diagnostic root canal therapy passing down to the tooth apex. So this is the regimen usually or typically taken by patients before the dental procedure. 1 hour before the dental procedure, 3 grams of oral amoxicillin, and it's given to these 5 cases, which all of them are considered structural abnormality of the heart. Regarding the pacemakers, we have 2 types. Temporary, to treat a temporary condition, and that can be removed, and the patient depends on his own conducting system of the heart for the heart function, for the heartbeats. And the other one is permanent, whenever there is a permanent damage in the SA node or any part of the conducting system of the heart, where there is a problem with initiation or propagation of the electric impulse inside the heart. These patients need to place a permanent pacemaker, and the permanent pacemaker is implanted under the skin in the region of the left shoulder, and the electrodes through the great veins at the root of the neck reach to the atria and ventricles. This is where the permanent pacemaker is implanted in the left shoulder. What is the problem? Actually, there's not a big problem. We just need to take care whenever we are using electrical equipment like ultrasonic scalers, the MRI, electrosurgery, and diathermy, because all these electric equipments can unbalance the pacemaker. So they are not contraindicated, but just we take care of the patient while performing these procedures. Temporary pacemakers, we spoke about it, that there is a risk in these patients of developing infective endocarditis, and they require to take an antibiotic prophylaxis against bacterial endocarditis 1 hour before the dental procedure. Cardiac arrhythmias. Cardiac arrhythmias can be precipitated by stress, and as we mentioned in the first part of this lecture, that dental treatment is stressful to many patients and also can be exacerbated by general anesthesia, and the arrhythmia can be made worse by anything which stimulates the parasympathetic system or the vagus nerve, the parasympathetic, like manipulation of the eyes or of the carotid sinus or the neck. Cardiomyopathy is a disease of the cardiac muscle. Whenever we get a patient with cardiomyopathy, what to do is to consult, take the advice of the treating doctor. Coronary artery bypass graft. When we receive a patient who has done coronary artery bypass graft surgery, we ask 2 questions. We ask the patient about exercise tolerance, and number 2, if he gets chest pain. Valve replacement, artificial cardiac valves, prosthetic heart valves. They have 2 problems with dental treatment. Number 1, these patients are taking lifelong warfarin, anticoagulant. And number 2, they require antibiotic prophylaxis against bacterial endocarditis. These are the types of the coronary artery bypass graft surgeries. They can be a single vessel, double vessel, triple vessel, or quadruple vessels. And as we said, we ask the patient 2 questions. Exercise tolerance, how he tolerates the exercise, and the second question about the presence or absence of chest pain. Congenital heart diseases in children. We have 2 categories of congenital heart disease. The cyanotic, where the patient, the child gets bluish coloration with exercise or without exercise. We call this category cyanotic heart disease. And the other category is the acyanotic heart disease. In cyanotic heart disease, there is hypoxemia, and hypoxemia can give manifestation that can be seen by inspection, like finger clubbing, the one seen in this picture. And number 2, they can give polycythemia. Polycythemia is a high number of red blood cells, which increases the viscosity of the blood and can predispose the patient to hemolysis or thrombosis. The dental consideration is infective endocarditis risk. These patients are having a structural heart abnormality and need to be protected by prophylactic antibiotic before the dental procedure. This is the picture of finger clubbing. Clubbing with finger is hypertrophy of the soft tissue in the nail bed as a result of chronic hypoxia, as you can see in the picture. And in these pictures, cyanosis. Cyanosis, we look for cyanosis in the oral cavity, in the lips and in the tongue. This is central cyanosis. And the other place we look for in the periphery, in the fingertips, and this is peripheral cyanosis. These are pictures of finger clubbing. This is normal fingernails. Dose reduction of epinephrine in the local anesthesia. We need to reduce or even remove epinephrine from the local anesthesia in hypertension, angina and myocardial infarction, ischemic heart disease, cardiac transplant patients, and patients taking beta blockers and diuretics, pheochromocytoma, and uncontrolled hyperthyroidism. Precautions with drugs and the cardiovascular system. The non-steroidal anti-inflammatory drugs the analgesics which we usually prescribe in most cases to the patients are nephrotoxic. And this nephrotoxicity is increased with certain cardiac drugs like ACE inhibitors and diuretics. Sedation under cardiac patients is very valuable for two reasons. First, sedation reduces stress, and secondly, this can eliminate the need for general anesthesia in this patient. Finally, anticoagulation and heart diseases. The warfarin, which is an anticoagulant used in many cardiac conditions like in atrial arrhythmias, deep vein thrombosis, DVT, prevention of embolization in cases of myocardial infarction, and in artificial heart valves. Warfarin is monitored by a laboratory test called INR, or International Normalized Ratio. Whenever we get a patient in the dental clinic who is taking warfarin, we have to check the INR on the day of the procedure. If our dental procedure is minor and the INR is below 3, this is safe and we can proceed with the dental procedure without stopping the warfarin. But, however, if our procedure is major, we have to stop warfarin for 2 days before the procedure and then resume on the same evening after the procedure. We have always to consult the patient's physician for adjustment of the dose whenever needed. And one last final thing, that aspirin should not be used in these patients taking warfarin. Another anticoagulant is heparin. This is monitored by another lab test, which is the APTT, activated partial thromboplastin time. Heparin is most commonly taken by hemodialysis patients with renal failure on hemodialysis. They take heparin in order to prevent coagulation of blood in the dialysis machine. Best time to treat these patients after the end of the effect of heparin, which is usually on the next day after hemodialysis. There are certain types of heparins, we call them the low molecular weight heparins, like tinzaparin, calciparin, enoxaparin, and these low molecular weight heparins have little effect on dental treatment. Thank you very much.